Okay, Paul, I think we should get cracking if you're ready.
Hello and welcome. My name is Paul Boateng, and I'm delighted to be with you today. In my day job, I'm a member of the House of Lords, now operating virtually, and I chair an organization called Water and Sanitation for the Urban Poor, which is working in 7 African countries and in Bangladesh as we speak. We are today coming together on the World Wide Web through Zoom for a very important and I think significant purpose. It's the first of a series of discussions. This is today's discussion is called Voices from the Frontline, Sharing COVID-19 Experiences from Africa and Around the World. And there'll be others in this series over forthcoming weeks. The purpose really is to give a voice to frontline practitioners. We are brought together under the auspices of BOBAB and Medicus, and you'll be hearing more in due course from Nick State and from Nicole Kayode in order to explain how it is that they've come together for this purpose. But we have a very specific intent, and that's to give voice to Africa's concerns and Africa's needs in the midst of this pandemic, to recognize that the solutions to Africa's problems are more likely to be found in Africa and with input from Africans than they are anywhere else. And to that end, let's actually look at where we are in Africa today in terms of the pandemic. The latest figures from the Africa Center for Disease Control and John Hopkins, which are just released, are 66,319 cases, 2,344 deaths, 23,143 recoveries. That number is growing and it's going to grow. And it will be important that we develop African responses to that challenge. We're very fortunate today to have an expert panel of people from the UK, the US, Kenya, Germany, Ghana, 3 continents to share their experiences and their insights. It's a very practical session. Over 90 minutes, we'll have an opportunity to listen to them, to ask questions after each of their presentations. So please let us know either through writing that question down in the chat room or putting your hand up and we'll come to you. We'll do that after each of their presentations. And then at the end, we'll have a general conversation. I'll ask everyone please to keep their points short and to the point. Also, and importantly, we're about analyzing where we are, but we're also about finding solutions. This is all action orientated. It seeks to answer the question, what's to be done, and to answer it in an informed and insightful way. And for that, we're hugely grateful to you all for coming together. Know also that our numbers will be added to by the fact that this session is being recorded and will be out there as a resource on the World Wide Web. So what you say, your sharing of experiences of what you're doing matter and will make a difference. And I'm going to ask Nick and Nicole just to say a few words by way of introduction. Over to you first, Nick. Nick.
I fell at the first hurdle, oh dear. Okay, there we go, unmuted now. Thank you, Paul, and thank you everyone for taking the time to be here today. As a quick introduction, as Paul mentioned, my name is Nick State. I'm the CEO of BOBAB. We're an event streaming and peer-to-peer networking platform dedicated to connecting science, tech, and business professionals working in and for Africa. We exist with a very simple purpose: to accelerate science, tech, and innovation happening in and for Africa. And we do that by working with partners like Medixus to host events such as this, the ambition being to make it easy for experts like those on this webinar to come together, to connect, to explore challenges and promote innovative solutions, ultimately to enhance collaboration. And I'm really delighted to be co-producing this series with Medixus, who I know are doing an awful lot of good work around connecting medics in Kenya and crucially facilitating knowledge sharing across Africa, which is something that this outbreak, I think we can all agree, has proven to be more important than ever, and is really the whole reason why we wanted to combine forces to host this webinar series to facilitate that exchange of information, of knowledge, of learning, and crucially the promotion of best practice, so that we can together work to fight against this dreadful disease, and hopefully do our bit to minimize the impact. As Paul said, over the course of 4 events, we'll be covering a whole range of issues. This one is focused on voices from the front line, but that will always be the emphasis of each event. The second one taking place next week is looking at mental health and the psychosocial impact of COVID-19. And I encourage you all to sign up to participate in those upcoming events. But for now, hand over to Nicole to explain a little bit more.
Nicole.
Great, thank you. Yes, as Nick said, we're really pleased to be hosting this and bringing together some people that we each know personally, including Dr. Boovy and Professor Yanka and Mark Slade, a really great lineup of speakers. At Medixus, we are at the moment working really hard to support the COVID response through our mobile app, which allows doctors to collaborate on patient cases. We're posting daily digests on what's been happening with the latest epidemiology, the latest pathology, all the things that doctors need to know on the front line, as well as offering up our enterprise model for free to facilities for 3 months to support them in taking their clinics virtual. So you guys on this webinar have received the sort of invite only link, and a lot of other people are also watching on YouTube. So hello to all of those that are tuning in there. And yeah, we're really excited to get this conversation going. And as Paul said, we're really hot on the idea of this being outcome-driven conversation. So as well as talking about the lessons that you've learned and what you've seen, and also the questions, it's really important for us to think about how we can turn that into tangible output, both in Kenya and also in some of the other nations we have joining us. Because interestingly, I think Kenya has, well, Africa as a whole, the continent has well, I want to say surpassed. People have expected it to be a lot worse on the continent than it has been. And although I'm sure that we're yet to see the peak, it's been interesting to see the early interventions, the different approaches in different countries and the effect that has had on the peak in general. So thank you.
Thank you, Nicole. And thank you, Nick. You know, one of the things that we know and do very well in Africa is to survive. But we're also witnessing some remarkable examples of success in combating the virus. So yes, resilience, important, but we're also seeing some real results in terms of new, exciting and innovative approaches, community-based approaches to responding to the public health challenge that we face. In the forefront of that, very much on the front line, is our first contributor, Dr. Paul Mbuvi. Paul is Deputy Head of Department Accident and Emergency at Kenya National Hospital, Kenya's largest public hospital, currently in the forefront of the COVID-19 response, and working also at the Mbagati Hospital. Dr. Mbuvi has first-hand experience of managing the crisis from a patient care and staff safety perspective, and we're all looking forward very much, Paul, to your contribution. So over to you.
Okay, thank you very much for this opportunity. I hope you can all hear me.
We can.
Okay, good. Okay, hello. As introduced, my name is Dr. Mutua Mbuvi, or Paul Mbuvi. I work at the Kenyatta National Hospital, which is East Africa's biggest referral facility. I work as a deputy head of department for the accident and emergency department. But since the COVID crisis began, I was moved to the COVID response team. So I currently work at what we call the Mbagathi facility, which is our COVID infectious disease unit that we currently use for treatment of patients who come in with COVID. So from our perspective, from the Kenyatta perspective, is that we have 3 facilities that are currently running. Maybe I'll share my screen with you so that you can have a look at what I have. Sorry, just give me a sec. Okay, so this is like a brief overview of where we are as KNH, but these figures are not the latest ones, but they are at least as up to date as you can. I haven't yet factored in the statistics for this particular week. It's been a very busy week for us at the facility. But like I said, we have 3 facilities that we run. We have what we call the KNH, stands for Kenyatta National Hospital. So we have the KNH IDU, or the critical care unit. This is where we have patients who require critical care, patients who require intubation, ventilation, and intubation and ventilation support. That is where we have them. We also have the Mbagathi facility, which is where we have now from mild to moderate patients who are usually admitted there. We have what we call our daycare center. It's not really a daycare center per se, but it's an isolation facility which is dedicated to healthcare workers. So any healthcare worker who develops COVID is isolated at this particular facility. That's what we usually have. Those are the 3 facilities that we run at the moment. Okay, just a second. Yeah, so that's what we run at the moment. So the facility is covered. We have a range of people who cover the facility. Key people include our specialists, our infectious disease specialists. We currently have 3. 2 for adult infectious disease and 1 for pediatric infectious diseases. We also have a team of critical care specialists from our main ICU and the medical ICU as well. We have respiratory and infectious disease specialists. This includes our pulmonologists and our respiratory physicians. We also have a team of medical officers who currently number 15, who do the day-to-day activities, the day-to-day taking care of the patients who are in these 3 facilities that I've mentioned. We also have a team of 46 nurses, a pharmacist, pharmaceutical technologists, and the key people that we have at the facility are the counselors, who we have come to realize are very important. They're very key in this particular scourge that we're dealing with. We also have our lab technicians, we have our physiotherapists, we have our radiographers. Those are the main people that we have. So we started out from the 13th of March. And from then, we have actually seen a total of 955 clients. And from these 955 clients, you have seen a total of them, there's some who have been discharged without having been tested. And this was at the very beginning when we had a case definition that included mostly a history of travel to a country where COVID has been confirmed. And from that, we've also had a total of 548 admissions, including of this 955, 832 of them turned negative as you tested them. We had a total of 82 confirmed cases as at the last time I updated this, which is about last week on Friday. And at that time, we had our mortalities have increased to around 3. And we've also had a number of foreigners from various countries who have been held at our facility, around 13 of them. Patients with comorbidities, including HIV, diabetes, and hypertension, have also been seen at our facility. As I said, the daycare center is where we have our healthcare workers. So far, we have been able to manage around 6 of these people, 6 healthcare workers at the facility. All of them have been stable, asymptomatic. None of them have required any critical care intervention, which is something we're very happy about. As you can look at our statistics, our major block of patients who we have been getting are between the ages of 20 and 49. That is our biggest block, which is basically the youthful population of our country. And the interesting thing about this statistic is that majority of them, this age group, are actually presenting with, they're actually asymptomatic at the time of presentation. So we are not getting any of them who are actually heading into who require critical care. We're actually having a very big number of them who are actually recovering, though some of them are taking a while before they actually recover. And our population above 60, we've had very few of them, actually 3 who we have admitted in our facility so far. And of course, the sex distribution seems to be the same as with the rest of the world. Majority of our patients is actually male. as compared to the female population. And if you look at the age distribution with the sex, like I said, between the ages of 20 and 49, as you can see, still the biggest proportion is our male clients, but we do have this peak where between the ages of 40 and 49, we have seen more women who have actually been admitted than the men in our facilities. That has been one of the interesting things that we've been able to do at the time. Mortalities have happened. We have had several of these happen. Most of these have been, one of the patients was actually an elderly patient, which also ties with what is happening in the rest of the world. This patient was a 65-year-old non-cardiac patient who had presented with features of what you call acute decompensated heart failure. And with that, once we did the COVID screen, we found that he was COVID positive, but unfortunately we lost this patient even after we had initiated critical care. And the other mortality we've had a mortality of one child who also had a comorbidity. This child had aplastic anemia, and at the time had gone through several sessions of treatment outside the country and had come back. And when we tested the child, we actually found that he had, was actually COVID confirmed, but that was found out after the child had passed away. So that has been our key thing. We have faced several challenges, especially with getting family units and also what I call persistent viral shedding. We have patients who stay in the facility for so long before they actually get the 2 negative results that they require for them to be released now for home-based quarantine. So we usually end up with them and they stay in the facility a bit longer. Our current situation is that we have a lot of families coming in. We have places where we find that the father, the mother, and all the 3 children are all confirmed COVID positive. And in our country, we are isolating anyone who is found to be COVID positive has to be isolated in a facility. So we now have to start thinking around how do we isolate families as a whole? Do we now decide to do this isolation at their homes and have a surveillance team keep checking on them? Or do we have them in the facility and keep them there until the time that they all turn negative? Those are some of the things that we've been getting. Caring for what we call asymptomatic patients who have been a big part of our patients that we have has been also a challenge. So we are currently in the process of evaluating how feasible it is to have home-based isolation so that we can leave the hospital facilities to deal with the moderate and the severe cases that we may end up getting as the cases continue to rise in the facility. And we still have a challenge with our turnaround time for our testing. We're still averaging around 15 to 24 hours before we get our test results back. But this is something that the government is currently working on to see how we can shorten this period so that we can get these results much faster and be able to take care of these patients at a much higher rate than what we're currently doing. The highlights of where I currently work is that we have a very good team. It's a big team, as I showed you the list. And we actually work as a team. Usually, one of our key things about team building is that we actually have lunch at the same time. So even though we have to do social distancing and spacing, but we actually have a time to actually talk and interact and talk about our patients, talk about our lives, see how people are holding up. We have a core team of psychologists and counselors who are accessible to the staff, the healthcare workers, and also to the patients at any time that you need them. They're there 24 hours. You can actually have phone call consultations with them. You can actually have one-on-one sessions with them or group sessions if you require, because we discovered that with the advent of isolation, especially for the patients, where they have to stay in the facility for up to 14 days. No one is allowed to visit you. You're in a room by yourself. You have really nothing else to do. So all these thoughts keep preoccupying your mind. There's all this data that is out there that's saying how there are patients who are dying of COVID. So there's that fear that everyone has. So the aspect of the counselors has become a very, very important part of our clinical management of these patients. And it's something that we're doing on a daily basis, and also including the healthcare workers themselves, because there's also that stigma that comes with, unfortunately, there's a stigma that comes with working in a isolation facility that deals with COVID patients. Because now when people from outside realize that you actually work in this facility, there's the impression that you may actually be bringing the infection to them, rather than you being the one who's actually helping to stand in the gap for them so they do not get this infection. So those are things that we have seen, and we've been trying to handle those ones. We've only had one critical critically ill patient, as I mentioned, actually 2, but the child was discovered much later after they'd already passed on. But there's one patient who was critically ill, and unfortunately he passed on despite our best measures. And that has been one of the things. But at the time of making this presentation, we did not have a critically ill patient at the time. So it was one of the things that we were thankful for, that out of the number of patients that we had, none of them at that point had actually required critical care. And like I said, the most important lesson we have learned so far, or I have learned so far, is the importance of mental health, both for the patients and the healthcare workers. There's a lot of stigma out there, even for the patients who eventually get released to go home for home quarantine. They face a lot of stigma, especially in the community, because even their neighbors start to treat them as if they're still carrying the disease and that they will infect them. So they're ostracized in as much as they live in the place. They're ostracized at any given time that they're there. So we have found that we actually have to continue with our counseling and our counseling services, even after these patients have been released from our facility, that we actually have to give a way in which they can still have access to our counselors, have access to our psychologists, so that they can still have someone who can take care of them in terms of their mental health, in as much as they've already been released from the facility. Those are some of the things that we have been. Yeah, thank you. Yes, I think
Paul,
that's most of my presentation. Thank you.
Paul, thank you very much indeed for that, and for being so succinct and disciplined on the issue of time. Now, can I also welcome to our group, Her Excellency, the High Commissioner of Tanzania. I wonder now, colleagues, have you got any questions for Dr. Mbuvi, for Paul at this stage, in which case we can put them straight to him, or would you like to hold them until later? So are there any questions? Now's your opportunity to unmute and to get in there and to ask him one.
I have a quick question.
Yeah.
Paul, have you noticed that your patients are presenting with the typical pattern of what we're seeing in other countries, where they say the sort of day 10 is the turning point for improving or getting worse? And of those that aren't critically ill, do they still have like ARDS type symptoms, or are they mainly towards the sort of lighter end of the symptomatic spectrum?
Okay, thank you for that question. So like I mentioned before, up to 90% of the patients we have actually had in our facility came in with very, very mild symptoms, and some of them actually asymptomatic. So we have had very stable patients in the unit. We have not had, except for that one critical case. So for most of these patients, when we do our next testing after the 14 days, most of them, a good number of them actually turn negative, and we do the second test after another 24 to 48 hours. They're negative. So then now we have the option of now discharging them and sending them to quarantine at home for another 7 to 14 days. So that has been our spectrum. Most of our patients are actually asymptomatic, and they're actually recovering quite well. But that the situation may be, it's different on the side of Kenyatta if you compare it now with other areas of Kenya, like Mombasa, for instance, which is also another place where there has been a lot of cases that have been reported. But Mombasa has actually reported more of the seriously ill patients as compared to what we are facing in Nairobi at the moment. For those who may not know, Mombasa is the second city in Kenya. It's located at the coastal region. So there the cases, their spectrum of cases is actually different from what we are facing, because their team actually has to deal with a number of critically ill patients as compared to what we are seeing in our side of Nairobi. Yeah, thank you.
Thank you very much indeed. If there are not any more questions, if we can go straight now to our next contributor. We're really glad to have her with us, Dr. Tanya Rogo, born in Kenya, currently in the United States, graduated from the University of North Carolina at Chapel Hill, and then the dual MD MPH program at Tulane. She did her residency at Inova Fairfax for children and pediatric infectious diseases, and she's currently based in the Bronx, in the belly of the beast, so far as the pandemic in the US is concerned. And we're very glad and grateful, Tanya, Dr. Rogo, that you found time to be with us today. So over to you.
Good morning from the epicenter of the pandemic. I'm going to go ahead and share my screen. Let's see. Share.
Great, we've got it.
Okay, so I work at Bronx Care Health System, which is the largest nonprofit hospital in the South Bronx. We're at 800 plus hospital. And at the height of the pandemic, at the beginning of April, we had close to 400 plus patients admitted with COVID-19, over 100 patients a day on mechanical ventilation, and unfortunately also up to 30 deaths per day. So very much at the center of the beast, as you said. And I'm going to focus this talk on the effects of what we've seen in children. But before I do that, I just want to give a background of what happened in New York. So essentially, we were caught unawares. The story was from the CDC that there wasn't an issue in the United States. The first couple of cases showed up in Washington State, and testing was not available. There was a testing issue at the CDC where the initial test that they had malfunctioned. There was very strict case definitions. And so we were behind the curve. So the first person who tested positive in New York City was a traveler who came back from Iran, which at that time was with Italy, where the cases were exploding. She was a physician who had quarantined herself. But then several days later, the second case was discovered, a lawyer in his 50s with no travel history. And that's when there was a clue now that there was actually community transmission in New York City. And things revved up from there, such that by mid-March, we had a shelter-in-place order for the entire city of 8 million people. And so looking at this graph, this is from the New York City Department of Health. You see here, starting from March 1st, which was the first case, cases peaked to the point that by the end of March, you now had 6,000 cases per day of patients testing positive for COVID-19. And we're just now starting to come off of that curve. And so in terms of the cases, hospitalizations, and deaths in New York City, we've had close to 180,000 people who have tested positive. In New York State itself, it's over 330,000 cases. So New York City has over half the cases of New York State. Almost 45,000 hospitalizations and close to 20,000 deaths in New York City. Unfortunately, everyone I know, including myself, knows someone who's been sick, hospitalized, or has died from COVID-19 because of the widespread community transmission. And New York City has 5 boroughs, and the borough with the most number of cases is Queens with 55,000 cases, but the Bronx, where I am, unfortunately, has the highest rates per 100,000. And so this, I'm going to come back to this to explain what we've seen in children. And the cases that tested positive were much higher if you were 45 plus in age. But I think that also has more to do with the fact that there was limitations in testing. And so testing was geared towards people who are hospitalized. Even at my institution right now, we're only testing hospitalized patients or healthcare workers. So we don't really have a true picture for what's going on in the community. And the CDC reported that in the US overall, 2% of confirmed cases were children under the age of 18. And in terms of deaths in New York City, being 65 plus in age is where the rates were highest for death. And so when this pandemic started, we didn't really know how COVID-19 affects children. The initial data that we had came out of China, which suggested that the clinical course was generally milder and that 80% plus of children were asymptomatic. Among those who were symptomatic, only 5% in the data that they published had dyspnea or hypoxemia, and only 0.6% progressed to ARDS or multi-organ system dysfunction. And that being younger in age, so preschool age children and infants were more likely to have severe disease, but there was no data on which underlying conditions put children at higher risk of having severe disease. And so when the pandemic started in the United States, about 6 weeks in, the CDC published the first set of data nationwide of COVID-19 in children. And what they showed was that it seemed like children had slightly less likely to be symptomatic. So 73% of children who tested positive have fever, cough, or shortness of breath, compared to 93% of adults. And that among the cases for whom they had information for underlying conditions, 23% had at least one underlying condition, with the most common comorbidity being chronic lung disease, including asthma, cardiovascular disease, and immune suppression. And also, we were concerned about perinatal transmission, and the data available at the time suggested that there seems to be no perinatal transmission. The cases reports out of China reported out of 17 tested newborns that there was no evidence of transmission, and that another report said that out of that there was 4 positive tests out of 34 newborns tested. And the symptoms reported in affected neonates was shortness of breath, vomiting, milk, cough, and fever. And so when all of this was kicking off in March, we had frequent meetings with neonatology and maternity and OB-GYN trying to figure out what to do. And once we had testing available at our particular institution in-house at the end of March, OB made the decision to test all women being admitted into maternity, regardless of whether or not they were symptomatic. And around the time that we started to do this, the Columbia group published a letter to the editor, to the New England Journal of Medicine, describing the experience over the first 2 weeks of them doing universal testing. So they tested 215 pregnant women, of whom only 4 were symptomatic. And they found actually that nearly 14% of asymptomatic women were positive for SARS-CoV-2. And among all the women who tested positive, close to 88% were actually asymptomatic at presentation. And so for us, we have had a similar experience that about 10 to 20% of women will have tested positive in maternity, most of whom are asymptomatic. And with this also, we had to decide what to do with these babies. And so what we decided was that all infants of positive mothers would get tested at 24 hours of life. Fortunately, none of these infants have tested positive, which matches with the general consensus that there's no perinatal transmission of COVID-19. And what we decided to do was repeat the test at 5 days of life if the baby was still admitted. And at the beginning of April, the American Academy of Pediatrics came out with a guidance on the management of these infants, which actually matched what we had been doing. And their guidance said that neonates born to women with suspected or confirmed COVID-19 should also be considered suspects and should be placed in isolation and should be tested. Separation of mother and newborn should be voluntary, of course, if the mother agrees, and also to isolate as is feasible. And for us, because we have in the Well Baby Nursery 2 nurseries, Nursery A and Nursery B, we turned Nursery B into the COVID-19 nursery where the babies are placed in isolates, and everyone wears full PPE to take care of those babies. There's no evidence of SARS-CoV-2 in breast milk, and so the mothers express breast milk that's fed to the babies. And the AP recommended testing the newborns at 24 hours and repeating at 48 hours. We have continued to do the second test at 5 days if the baby is admitted. Now, the next thing that we had to figure out, though, is because these mothers are positive, is at discharge, how to discharge the baby. And so the social workers had to identify a healthy adult who could care for the baby, because the mother was supposed to be isolated for the 14 days, generally 14 days after her positive test. Unfortunately, for all of the mothers, either it was a father or an aunt or some other healthy adult was identified who could care for the baby. And the other additional planning that had to take place was how to do the well infant care in clinic, as we knew that the mothers were positive and we didn't want these mothers coming into the waiting room and exposing other families. And so we've designated 1 day of clinic a week, that's the COVID day, where these mothers are come in. But generally, we try and keep these babies out of clinic until 14 days because hoping that for most of the mothers, they will no longer be shedding, though we know that some people shed for a prolonged period of time. And in those first 14 days of life, the pediatrician does a televideo visit with the family at least weekly to check in to make sure that the baby's okay. So our initial fear that that these babies would maybe come back sick initially seemed to be that the babies remained well. And on the general pediatric units, we found that generally, as other people have seen, is children seem to not get very sick. So our numbers were down, admission numbers. Usually we have 100 plus admissions a month, and we only had 37 admissions the month of April because people stayed away from the hospital. People were scared to come in, but also children generally were not very sick. So we had 10 positive tests. The youngest was 3 months old, a former premature baby who actually ended up doing well. We did see co-infections. We had 2 co-infections with human metapneumovirus, 1 with parainfluenza, and we had 2 cases also with urinary tract infections. So definitely for people taking care of children to be aware that co-infections do happen. The most common comorbidity that we saw was asthma. Only 1 of the patients developed ARDS and required to be transferred to a higher level ICU because we thought that he would end up needing ECMO. And we had 1 case, an 18-year-old who developed myocarditis, but it was stable. And actually we spent more time managing his UTI, which ended up being from a multi-drug resistant organism. So he also, in terms of the myocarditis, did well. So we thought children were okay. Then at the end of April, the Pediatric Intensive Care Society in the UK reported cases of critically ill children presenting with features of Kawasaki disease and toxic shock syndrome, some of whom tested positive for COVID-19. And around that time, we had 2 children come in. The first one was a 5-year-old who came in with abdominal pain and diarrhea. It looked like gastroenteritis, was admitted for rehydration. And after 2 days of admission, developed fever and hypotension, ended up having myocarditis. He tested negative twice by PCR and ended up transferring to be placed on ECMO and ended up testing antibody positive. And unfortunately, that child died. So he's the first case that was reported last week of dying from this new pediatric multi-system inflammatory syndrome. And
thank you.
Yes.
Thank you. Thank you very much indeed for that. And I think there will be some questions about this new development. So we'll go straight into questioning if we may, in order that your fascinating presentation and also particularly the point you ended on can be explored more. So any questions? Yes.
Yes.
Professor Sir Christopher.
Yes.
No, in a minute.
Okay.
Professor Sir Christopher Edwards.
Hello, Tanya, that was a very good presentation. Obviously, the worrying figure was this 13.7% of your 215 pregnant patients that tested positive but were actually asymptomatic. Is that representative of the general population? I mean, that's the key figure.
Yes, we think so. We think that there's a large number of people who are asymptomatic, unfortunately.
Now, in that group, you said that, in fact, that obviously some went on to become symptomatic. We think we've lost you. I don't know.
On people being responsible for themselves and staying at home. We think that that's part of the reason
we're losing you, Dr. Rogo. Dr. Rogo, we lost the last bit of your reply to Sir Christopher.
I said that we think, yes, that there is a significant asymptomatic infection rate, and we think that's part of the reason why there's been such intense widespread community transmission in the city.
Thank you very much indeed. I'm going to take one more question before we go actually to Professor Dr. Charles Yanka. So is there anyone else apart from Dr. Yanka who has a question?
Me again.
Yes.
Tanya, that was really interesting. Thank you for that. You interestingly mentioned that it seemed like asthma was a bigger comorbidity in children, whereas I think in adults the trend has been kind of obesity and high blood pressure seem to be more indicative comorbidities. Have you seen that asthma is also a serious comorbidity in adults, or vice versa in children with obesity? Has that trend also continued in the pediatric unit?
So we did see that obesity was definitely an issue with the young adults. So as things were intense and we had less pediatric admissions, we actually started to admit up to age 30 in pediatrics just to help our adult colleagues. And actually all pediatric units in the city did the similar thing, either going up to age 30 or going to age 45. And what we saw was obesity definitely was a risk factor. Where I am in the South Bronx is an extremely high rate of obesity. And I would say that I would say maybe 90% of the young adults that we admitted had a BMI in the obesity range.
Thank you very much indeed for that. And fascinating presentation, Dr. Rogo. Dr. Rogo, will come back to you, if we may, early in the general discussion, because I know our next speaker has a specific question for you, but you can deal with that in the general discussion, because we're now looking forward enormously to the presentation of our next speaker, Professor Dr. Charles Yanker. It's a great privilege, Professor, to have you with us, not least because of the obvious significance of comorbidity in this area, and aspects of cardiac and vascular health are clearly highly relevant. Professor Yanker is Professor of Surgery, Cardiothoracic and Vascular Surgery. He is a co-founder of the German Heart Center in Berlin, indeed, where I first met him. Is also a founder and CEO of the Global Heart Forum, ambassador to the World Health Summit for Developing Countries. He brings extensive experience both of Germany, of Ghana, and indeed has been a recipient of the National Institutes of Health Award at Bethesda in the USA, as a pioneer in introducing artificial heart programs in Africa. So, Akwaba, as we say.
Thank you.
Welcome, Professor Yanker.
Right, thank you. May I share my slides? I would like to share my slides.
Now, is someone going to put them up for you, or are you going to put them up yourself? This is always a tense moment.
Yes, let me see. Yes.
You got them?
Yes.
So have you pressed that little share button?
Yes, I got it.
Great.
Okay, the slides are there.
They're not up yet. Nicole, have we got a plan B?
Well, I'll just walk you through it and we'll try one more time. So if you press the green button for share,
Yes, I have.
and then you press the one with your slides on it. So
Yes.
when you, there you go.
You got it.
They're up. Very well.
Yes.
Good.
That's it, right?
That's it. You're there.
But it's not running.
You press on that one. Nicole, you're the expert.
Right.
Right.
Okay. Right. Well, thank you, Lord Boateng, and also Nick, for inviting me to join this interesting webinar. I don't want to go further in the introduction because Lord Boateng has already presented. I would like to just share our experience from Germany to Africa, because the concept of our society, the African Cultural Institute, as well as the World Health Summit, is to spread experiences from all over to join fellows in Africa in sharing their experience with our experience and exchange ideas. We have already started in response to the COVID-19 series of webinars. The first one was on the 3rd April, and the second on the 17th April, 8th May. In 3 days' time, there'll be another webinar with different topics, since we know that the comorbidities might be the important aspects of COVID-19 spread in Africa. So we would like to share our experience here in Europe, as well as also with our colleagues in Africa, so that they know what to prepare for any eventualities. We shouldn't also forget that we have some epidemic diseases in Africa: malaria, tuberculosis, HIV, even meningitis. So this COVID-19 actually is an added challenge to the African countries and also to the communities, so that the approach to this disease might be probably differently as they see it also at a different stage. Well, the major issue in Africa at the moment is the economic impacts of this COVID-19 lockdown. As you can see from the slides, which I got from the BBC, that they are rather struggling at the moment through the lockdown with food shortages, and that's starvation, and that's the major issue which might even develop unrest among the communities and the society. Well, we also have to consider the economic impacts of this lockdown. And there are three models of economic development which have been laid out, which we think the African governments and then the authorities have to see how this can be well organized, so that things are prepared properly with the help of course, the Western countries and the NGOs. We have the L curve, as you can see, where the economy will get down slowly, with a flatten, and the U model, as well as the V model. So these are the models one have to bear in mind and see how we can approach it. The fatalities in Africa, it's already mentioned by Lord Boatin, so I won't go into further. And the worst scenario that's we have to see that faced is the predicted deaths from coronavirus if nothing is done. If you take such a scenario without any response, any active response, we are expecting in Nigeria over 392,000 deaths now or later. Ethiopia over 265 and so forth. So that these are the figures that we have to bear in mind and see how we can also join our colleagues and friends and also the politicians to discuss with them and see how they can also do something to get things moving. The most important also issue is, as the colleague from Nairobi said, well, intensive care units is also a very important aspect of the COVID-19 response, but not always necessary, as we see that many of the COVID-19 patients in Africa are younger patients, and they might not need intensive care. But despite that, there is a need for a response, active response, by organizing also intensive care units so that those who might need them will have also access to them. The studies, we did a study questionnaire actually in March, and we realized that the intensive care beds in Africa are very, very low. So in case there's any epidemic, there's going to be tough so far as intensive care, critical care management is concerned. And this stuff, we are hoping that this will not happen. Well, the perspectives of this COVID-19, as we all know, since there are no vaccine and also no any medication, we have, of course, we have to stick to the general rules laid down by WHO and also the various governments, CDC authorities, social physical distancing, PPEs, face masks, and also hand and domestic hygiene. There is also another opportunity or possibility to use convalescent plasma in case any such blood bank system is available in Africa, which I think most of all the regional hospitals have all these facilities to organize convalescent plasma also for treatment. We hope that the remdesivir, the anti-Ebola drugs will be in place very soon for clinical work. Well, how does face mask protect you and others? This is also very important thing that one has to also bear in mind. If you take a COVID-19 subject, which is positive but asymptomatic, he might even also infect either a friend or someone in the community, even if he has a face mask. That is about 70% possibility. Whereas if he has the COVID positive, but even asymptomatic, has a mask, he might not infect his neighbor or other community. Whereas both of them, there's a possibility of infection at 5%. Whereas if both of them wear masks, the possibility of infection each other or the neighbors is only 1.5%. So these are important information that we also have to share with our colleagues and also in Africa, so that they can then advise and consult their colleagues. And regarding also the spread of infection, also very important. It means we have to do more testing in order to find out also the rate and then also the velocity of infection rate in order to get the so-called reproduction rates, which might be 1 or below 1, which is more important, so that lockdown of the society can then be considered in order to be on the safer side. Why it's also very important regarding the tracing of contact tracing of the patient, of the people. It's also very important in order to see how many people are also involved or infected. And this can also give us more information about how then the tracing, tracking, and getting the people for quarantine either at home or in the hospital in case they are symptomatic. Well, I want to show you this app system because I think if this is introduced in Africa, this could be a very important tool, not only for this tracing work, but also for the so-called, the health clinic. That's the tele-clinic program, which can also be very, very important and helpful for tracing and also for advising people with chronic cardiovascular disease or any other healthcare disease who are afraid to come to the COVID clinics because they don't want to get infected. I would like to end here and then give time for discussion. Thank you.
Thank you very much indeed for that, Professor Janke. And we will certainly want to come back to you on the issue of the app, because that's something I know where there's a great deal of interest, how we can use the degree of connectivity, increasing degree of connectivity there is in Africa, and the capacity for technical innovation to counter this virus. Time is running out, so for yourself, Mark Slade and Amit, I'm afraid we are going to have to deal with your questions in the course of the general discussion. So without further ado, I'm going to move on to Dr. Mark Slade for his presentation. Dr. Slade, Mark is currently consultant in respiratory and general internal medicine at the Cheltenham Hospital. He's also worked as medical director and consultant respiratory physician and clinical director of thoracic services there. And he's an appraiser of medical directors for the NHS and a leadership mentor. So very, very much involved with our own response in the UK to the virus. Over to you, Dr. Slade. Mark.
Thank you. Let's see if I can work the tech.
Yep.
Good. Well, thank you. It's a great privilege to be invited. I'm very excited to be taking part today. I have no conflicts of interest to declare. In 10 minutes, this is obviously going to be a very selective overview of what I've learned. Also, because of time, there's more on the slides than I'll be talking about, but I know they'll be shared with participants afterwards.
Thank you.
There's an issue of why would you want to listen to me when we've had participants from Germany and Kenya, and the UK is not exactly leading the world in the success of its response in this disease. I tend to think very visually, and so I sketched out, when Nicole asked me to speak here, the things that I thought were important on a national level at the top left of this slide, at a kind of hospital level at the top right, and as a doctor myself looking after COVID patients. And at the risk of frustrating some people, I'm not going to really talk about how the hospital responded to COVID in this talk, but I'd be happy to in questions or afterwards if people want to contact me. And I think we've all got views on how our nation has responded. I'm not going to go into that either particularly, except I would like to pose a question for people to think about. How is it that the UK has wound up with the highest recorded number of deaths from COVID in Europe? Started the first wave of the epidemic with one of the lowest numbers of intensive care beds per head of population of any developed country, and yet has been through it without the intensive care capacity ever being remotely overwhelmed. Somehow people died without troubling the intensive care units, which is a concern to me. But I want to talk about what I've observed or learned from managing patients with COVID in my own hospital. And so I think the key lessons for me as a respiratory physician, which might be relevant in various healthcare settings. First of all, I want to say a bit about the patients who can't be managed with oxygen alone and require more advanced respiratory support, initially with continuous positive airway pressure or CPAP. We've been able to do this. Before the epidemic, we thought about how we would do this on a big scale, and we developed a very simple system. There's no doubt that it saves lives. We found that it can safely be supervised by non-specialist respiratory nurses on an ordinary ward. Doesn't require HDU kind of nursing levels, but you do need access to some specialist advice. If you'd asked me before the epidemic how easy did I think it would be to persuade an overweight, breathless, hypoxic patient to lie on their front to help their oxygenation, I would have said very difficult. But it's turned out to be much easier than expected and quite effective for some. I've got some reflections on working in full PPE and the effects of that on staff. It's been depressing to see how good a culture medium for anecdote and fake news and general rubbish a pandemic has been. But on the other hand, the kind of can-do attitude and the everyone on the same page has meant that the UK has been able to set up and recruit to clinical trials in what would be regarded as unimaginably quick timescale. And the other initially helpful but disturbing element is that all the rest of our work has disappeared. As Tanya alluded to, people are too scared to come to hospital, and they must be having their heart attacks and strokes and other pneumonias and diabetic emergencies, but they don't come to hospital with them. So what do I mean by simple CPAP? We thought about how we would be able to dramatically to increase the scale of respiratory support in our hospital. And we just got a whole load of these very basic machines. They cost in the UK £200. I don't know what it is in your healthcare system. It has only one adjustable control. You can either switch it on or switch it off, and the pressure is fixed. It can be set at different pressures, but once you set it, you can't adjust it. So it's very simple. We used full face masks to avoid problems with different size noses or different size mouths. We obviously have to filter the expiratory gas to remove virus. And I've provided a link to guidance from the British Thoracic Society about how to set up non-invasive ventilation or CPAP for COVID patients. We found before we started that many of our masks were vented masks, which are fine for treating patients at home with obstructive sleep apnea, but are otherwise a good way of blowing aerosolized virus around the ward. So we had to change those literally with super glue to block up the holes and then provide an expiratory valve elsewhere. If those listeners who may be interested in respiratory medicine, I can provide some advice about that offline. But by just providing this very simple system with non-specialist nurses helped by access to respiratory nurses acting in an advisory capacity, we found that a great proportion of patients could be managed with this simple system alone, and that actually if you failed treatment with this simple CPAP, your chances of surviving then when you went to ICU for mechanical ventilation were actually quite low. So if you were in a setting where you had to regard CPAP as your ceiling of care, you're not disadvantaging many patients. I was asked at about an hour's notice to provide a talk in my hospital about CPAP to staff who were anxious about how to do it and things, and it turned out to be videoed and put on YouTube, so I've provided a link to that if anyone's interested.
Thank you.
This photo is taken from some guidance at Guy's Hospital about proning, just an example of how you can get a patient to lie down prone. This is my grandson's response to COVID. It's a very, I know that you're having a whole separate webinar on the psychological impact of the disease, so I'm not going to spend much time on this, but it is massively important. If your staff don't feel safe, they won't come to work, so you must sort out PPE and things. There's silly things. You can't separate a young doctor from her or his mobile phone. It would be easier to cut their arm off. So you have to figure out how they can safely carry it around the hospital into and out of COVID zones and so forth. And the whole issue of the terror and isolation that patients and their relatives feel, it has a big impact on healthcare professionals. I've mentioned the pervasive and pernicious influence of anecdote circulating. But on the other hand, I just want to mention the recovery trial in the UK, which was set up from first concept to the recruitment of the first patient in 9 days. And by day 25 had recruited 5,000 patients and is examining on a randomized way these treatments, all of which have been mentioned and in some settings as regarded as unethical not to give them, and then subsequently they turn out to be harmful in the case of hydroxychloroquine, for example. So a really important trial. Like any emergency situation, communication is incredibly important. It's depressing to me how often you have to explain to people that it's important to tell the truth, and some people think you can kid people along and so forth, but it always comes out in the end. But in our messaging, we always try to include something uplifting in the message each day. And if you want something uplifting and COVID related, I would suggest clicking on this link, but not while I'm speaking, please. Your experience of COVID, I think, will be, as Tanya illustrated, really massively influenced by the kind of nature of the population your hospital is serving. If you can see here that if you're in an urban or rural area of the States, there's 100-fold difference in the number of deaths per head of population. So good things I've learned from the pandemic, been massively impressed with the can-do cooperation across the hospital and the appreciation for one another and from the public. There's been enormous progress on telemedicine and simplification of procedures. Previously, it was almost impossible to get new technology implemented in the hospital in a timely fashion because of worries about data protection and so forth. Now, no one gives us stuff about that. It's just get it done, you know, ward rounds on Zoom, no problem. And I've mentioned the trial setup. The not so good things, as I say, proliferation of anecdote, treatments becoming recommended with no evidence whatsoever, patients too scared to come to hospital. And a really important one, I think, infection control concerns trumping compassion, which I don't think that should ever happen personally, but that's a very personal opinion. And I think in our country, we've wound up, you know, singing the praises of the NHS while neglecting the equally important social care settings.
Thank you very much for that. You've told us the truth, unvarnished, but you've also given us some cause for optimism and also some really good practical takeaways there, for which we are extremely grateful. If I can now go to Dr. Amit Thakkar. Dr. Thakkar is the president of the African Healthcare Federation, executive chairman of African Health Business, chairman of the Kenyan Healthcare Federation, currently serves as a director with AMREF, amongst others, an active member of numerous institutions in Nairobi, and importantly sits as an advisor to the East African Association, as well as to Asia Africa Investing and Consulting Limited. Amit, thank you very much for making time to be with us today, and over to you.
Yeah, thank you, Chair. Thank you to the organizers and all the previous panelists. I am delighted to be given this opportunity to really talk about the private sector. I'm sure a lot has been covered earlier. I apologize, I won't be able to stay till the end, but I thought I'd use my 10 minutes to talk a little bit about the private sector, Africa, innovations, and touch a little bit about the economy, because everybody's trying to think about opening up the economy and literally get back to normal business so we can retain jobs and have some sort of normal life. So what will it take from the health experts in order for us to ensure that the economic team gets on their footing appropriately? So let me start by just saying that the kind of work that I do hinges a lot around the private sector and embedding that in the health system. And in Africa, you can see how wide the private sector is. It can sort of encompasses all these players that you see here, informal, formal facilities, FBOs, CSOs. So it's actually non-state. And half of the care given on this continent is given by non-state actors. So once we tighten the public health system, but we don't tighten the private health system, then we will have missed out half of the place where the COVID outbreak needs to be also contained for treatment. Not only are the services that are really strong in Africa from private sector, but so are products. So the supply chain is critical, being provided by the private sector. And one thing that most people do know, and many of you are work in different parts of Africa or are affiliated, is that the SMEs play a critical role. And if we don't protect the small and medium enterprises, either through an economic stimulus or some financing envelope, then bankruptcy to the healthcare sector in those far-flung areas is very imminent. So with the GDP allocation by the government in developed nations, they have the luxury of enveloping with some pounds and dollars. In Africa, we need to be a little bit more careful and plan this ahead. One of the advantages is that we are pretty sure that the public-private partnership is going to be a strength when they work together in these 6 areas. And looking at the leadership by Africa CDC and Africa Union in governance, I think the HRH, financing, technologies, service delivery, also the information through media so that we get facts and not fears being pushed through as messaging is critical. So this is where I believe is the key role of the private sector. I wanted to put into context the way the organizations which are based in different parts of Africa are coordinated, especially the health sector. So at the bottom, you will see how the Kenyan sector works closely with the Ministry of Health, with the representation on the MOH task force, as well as at the Emergency Operations Center. And we work closely with the Kenya Private Sector Alliance, which is KEPSA, which works closely with the Office of the President. So this was just a busy graphical representation of how countries in Africa are coordinated upwards towards Africa CDC and Africa Union. And on the right top, you will see the Africa business groups coming together quite nicely in a platform known as the Africa Response to COVID-19 platform, known as the ARC platform, and works really nicely with the Africa 19 Response Fund. And these are all institutions in progress. We are lucky, we're fortunate, we're a little bit on the morning of the outbreak. We've witnessed what the other countries have gone through in the continents. So we've got a bit of time. And if we use our time effectively and well, I think we should see very well the efforts to flatten the curve. Talking about Africa CDC, let me just share 2 or 3 slides. And the priority right now is, of course, testing. You can see from here that we're way behind what Italy, South Korea, US are doing on tests per million population. Now, tests don't come free. Test means there's a cost. And one needs to decide, do you buy tests or do you buy food? And once you have to make that objective compromise, you need to understand that doing tests is important for economy to open up. Everywhere we've seen is if the virus is slowing down and we've been able to contain the outbreak, you allow economic activities to spur up. And so having mentioned about tests, you can actually see the number of tests that have been done in Kenya, Ethiopia, and selected African countries. We all know that South Africa and Ghana have done pretty well in the total number of tests, and the yield generally tends to be between 2 to 3% of which ones are positive. Rwanda is at 0.7%. They've done quite a bit of tests and they've had no deaths. So, as you know, Partnership for Accelerated COVID Testing, known as PACT, was launched at Africa CDC. We're hoping to get close to 10 million tests coming in soon, to 15 million tests. So the test kit supply is one big box that you see on the left, set up an Africa-wide pooled procurement system. And I think this is where, again, the private sector is playing a very key role in ensuring that we get it at the right price at the right time. The second part is a little bit difficult. It's the capacity building and training people with SOPs and having experts using the machines which are sophisticated, like the ones of Roche, maybe gene experts, are what we need to start putting through, because I think the real tests for us in Africa right now is the antigen test. So many countries have probably wasted lots of money on antibody tests that are weak and generally provide you high levels of false negatives and false positives. We don't have the luxury of throwing pounds or dollars behind ineffective tests that have no impact on either the safety or the value of patients. Then the third part is private sector engagement. And this is where our organization is deeply involved in making sure alternative testing platforms like Gene Experts are looking at more sensitive serological tests are explored. Engagement with the private labs. In Nairobi now we have from none to at least 7 or 8 organizations in private sector that are helping the government efforts in testing. So engaging private labs is important. The idea of sample collection and transport and the logistics is important, using drones, using motorbikes, collecting the samples in a timely fashion, using mobile vans. South Africa is, decked out 73 vans with a PCR machine in them that have also helped them to raise up the test. Scale up local manufacturing of key commodities, again, engineering, 3D printing, using models that I saw earlier, like the masks, oxygen delivery mechanism, respiratory aids. It's incredible what Africa has done, moving their manufacturing to respond to the COVID emergencies that we have. I think it'll make the African manufacturing team quite strong post-COVID. And technology applications to support contact tracing. I think we've seen telemedicine, telehealth on the health side, but also on the monitoring and surveillance side is something that Africa needs to work on very quickly and manage. As I end, I just want to quickly talk about the 3-planned approach known as Plan Ahead and Thrive, Contain and Crush, Repair and Reinvest, and Lift Off and Growth. So companies need to get out of COVID and have this view of that it's all going to be establishing new markets through leadership and partnerships. I think will be stand up to be counted in your own companies and in your own organizations. No matter what you're doing, the kind of leadership and partnership displayed now will determine what happens in the future. So it looks a bit grim. You can see how the GDP is getting affected in most of the African countries, and including the world. Look at USA's GDP decline, Uganda, Ethiopia, South Africa. You've all seen this kind of statistics in many of the documents that you have read, but there are those organizations it'll have a minor hit. There'll be some organization that'll have a hit, but a rebound, and health equipment is part of that. But then there are those who will have hit, but no full rebound. And this includes banks, durable goods, transport, retail, and you can see organizations that are really affected, like Kenya Airways. Insurance companies are going to have a hard time. And these are listed companies just taken off the Nairobi Stock Exchange. When we looked at their average stock price variation between February and April on the right. And on the left, you will see the US industry companies of the similar groupings. There is similarity in the graphs, as you can witness on this slide.
Thank you very, very much indeed for that, Dr. Thacker.
I've got 2 more slides. Just hold on. I'll finish. So the global recession is likely with economic shocks. Already either you get a V or a U or an L shape. So it depends on exactly how every country gets into managing this current crisis. You've all seen these 3 graphs.
Yep.
Just as I end, there are 3 ways of dealing with it. Sweden deals with it in protect and provide, and then crush and contain South Korea and China. But since we're talking about Africa, we will be taking more like the flatten and fight approach, which will enable us to increase health capacity. You buy time, and then we will see us recovering. So thank you for your time. And we are very delighted to partner with you at this webinar.
No, Dr. Thacker, thank you for your time and for that extremely insightful presentation. It's so important to recognize the role of the private sector. No, there can be no public health or health solution in Africa that does not recognize the multiplicity and complexity of the sector and the importance of the private alongside the public sector, the traditional alongside the modern. Absolutely critical. I wonder if we can now, in thanking you, go into our discussion, an opportunity for people who haven't spoken so far, or maybe who have asked a question so far but want to say more, to say something. I will be coming at the end to all of our speakers who remain with us to make their final closing remarks in which they may answer some of your questions. Other questions may well have to be taken offline. But if we can begin with questions, contributions, over to you. Who's going to kick off? Well, let me, in that case, take the...
Paul, sorry to interrupt, Paul. Sam Mardell has raised her hand, if you'd like to invite him.
Sam, please, over to you.
Hello. My question is more about the public health aspects of COVID, the pandemic in the long term. I was reading a rather interesting article about, I think it was talking specifically about Nigeria, but the fact that people aren't allowed to travel has brought home to many wealthier groups the low priority that had been given to national health services across Africa. And I would be interested in hearing people's opinions on whether or not they think that will change in the future.
Yes, good. That's a great one. The fact that BA and Qatar can no longer take people to New York or to London or to Dubai or wherever it is for their medical services, are having to look at home and seeing just how poorly actually Africa has served itself in terms of health spending. Very important question. We'll hold it, and others will have points they want to raise. If not, before he leaves us, I'm going to go to Dr. Thacker and also to Professor Yanka for some response on that one. The evidence seems to be that most African countries have not met their AU targets on spending on healthcare in terms of building and creating sustainable and holistic healthcare systems in their countries. And the evidence is that it doesn't actually, it hasn't featured as high up on the political profile as it might, because political elites always get their medical treatment elsewhere. Dr. Thacker, what have you got to say about that?
It's a good question. And as you all know, before this pandemic, we were talking about UHC and as the SDG goal number 3. As you rightly say, Mr. Chair, the AU targets were about 15% of the GDP, and many African countries, only 2 African countries met it. And a lot of discussion was around, you don't need more money for health, but you also need more health for the money. So efficiency in the governments was also a big topic, because corruption and waste was probably leaking close to 40% of the resources. Not only we had a weak health system, but there was a leaking bucket that made it weaker. So the elite kept traveling. Medical tourism in Nigeria about a few years ago was $1 billion, just one country. And so people bought healthcare. So in every crisis, there's an opportunity. I firmly believe that in 6 months, we will have a situation of critical care in Africa that will go up, regardless of whatever happens to the infections and regardless of how many deaths we see. We will also see collaboration amongst African countries going up. We will also see sharper and smarter supply chain management. So the question is very interesting. And when you literally have to take healthcare in your own country as presidents, you will now be very careful and mindful of how Africans are serving Africa. So that's an opportunity in this crisis.
Thank you, Dr. Thacker. Professor Young.
Yes, I think just a comment to the previous speaker. We believe that generating money within the public sector, as well as also from the society, to develop a health insurance system is the ideal one. For example, in Ghana, you have to pay about a levy of 15 to 16% of all the products that you buy or use at the restaurant. So this can be used to more or less develop a healthcare insurance system for the primary as well as for the secondary healthcare system. And if we're able to do that, and this is a lesson that we are going to learn from the COVID-19, that we have to now exert our own efforts to develop our own system of healthcare system. And I'm sure this is going to be an approach where United African countries, that is probably going to be geared by the AU, to see that the next decades or the 2 decades coming, a health insurance system is now becoming a very important priority in the healthcare management of Africa.
Thank you very, very much for that. Nicole, you've got a couple of questions that have come in from our participants across the World Wide Web in written form. Over to you.
So we have 2 questions, one from Janet Chapman, who asks if CPAP machines are widely available in Tanzania. And the second question is from Patrick Karagu, who says that wearing of masks does not seem to be a stress directive in both the UK and the US. So what would be the view of both Dr. Slade and Dr. Rogo on that subject? Thank you.
Thank you. So any responses?
Well,
Mark?
So I think the government, I think the issue about masks in the UK is there are a couple of things. I think and I don't think the government is in being entirely frank with the population about them. There's good evidence that masks reduce the risk of transmission, including from the Health Protection Agency in the UK from about 20 years ago, where they looked at the transmission of virus through various masks, surgical masks, higher spec masks for the N95 or PPE. And there's good evidence that they reduce transmission. I think the concerns are twofold. One is whether, if you said people should wear masks, surgical masks, that would mean that there was increased competition for the available supplies and that they wouldn't be available for higher risk settings. And secondly, whether members of the public can use them safely, wear them appropriately, dispose of them safely, and whether they would encourage riskier behavior when, in particular, if it was riskier behavior without using the mask properly, you'd actually increase your risk of catching COVID. So, but I think there's good evidence that properly used, they reduce transmission. And if there isn't, we'd want to know why they've been the primary defense for healthcare workers, other than in intensive care units in the UK. So I don't think, and that's another example of why I think it's important to tell the truth to people.
Dr. Slade, thank you for that. Dr. Rogo, we see pictures now of apparently everyone in the White House except the president and the vice president has to wear masks. What's your take on it all?
I think, unfortunately, what's happened in the US is that we have leadership that disputes what the public health authorities say. And so the president has been steadfast in refusing to wear a mask. He doesn't think he needs to wear one, which confuses the general public when the CDC has made that recommendation. And so I think it's unfortunate. And I think we're going to see things evolve as there is now coronavirus in the White House. What's really going to bring this pandemic to a stop is public health. But for as long as there are countries such as the one I'm residing in, where the leadership, for whatever reason, refuses to listen to the public health experts, it's going to continue to be an issue.
Thank you very much. Well, if you can't change your message, maybe you should. But that's for another occasion, no doubt. But we have this important question about CPAP. Is that what you call it, Mark? How available are these machines, or can these machines be in Africa? We had a specific question about Tanzania, because they do seem to be able to address the point that Dr. Yanka illustrated, that actually the intensive care facilities in many African countries are negligible to non-existent. So maybe machines like this can play a role. Is much known about their availability in Africa? Mark, can you shed any light on it?
I'm sure there's much known about their availability, but not by me, sadly. I don't know whether Nicole could come.
Might be welcome to answer that.
Nicole, can you answer that?
I can't, but I think Paul or Amit might be the best ones to answer that.
Paul,
have you got much experience with CPAP?
Mbuvi or Dr. Thakar? Dr. Mbuvi, we've not heard from you from a bit. What's your experience in relation to CPAP and other ventilating mechanisms?
Okay, so far with the current cases that we have got, CPAP machines are not that readily available, especially in our hospital. We have a few of them. I think we have like 3 of them, and most of them are actually at what we call the critical care unit, that is separate from the unit that is housing the COVID-19 cases. It's even separate from the COVID-19 place where we actually have our unit for our own critical care. So our current plan that we are using at the moment is that we have invasive ventilation. We are using, we have to intubate our patients and put them on ventilators. And that is the current side that we're actually moving on. We are trying to build our capacity and having our ICU beds and our ventilators to be at a point where if we do get to that level where we are getting more cases that are critical, that we will be able to handle them. The good thing is that with the government initiatives that were put in place in terms of having a curfew and limiting movement of people from certain areas of Nairobi and certain areas of Mombasa, is that the number of cases has actually increased at a steady pace that I believe personally has allowed other facilities outside of Nairobi and outside of Mombasa to have the time to actually be able to prepare themselves to handle the cases as they come in. So this in a way has flattened our curve, not so much, but it has given us like a buffer zone where we have the capacity now to actually prepare ourselves and prepare our healthcare workers, have a good stock of our PPEs, have these critical care units and isolation units set up in various counties in the country, so that by the time we do hit the level where we're getting numbers that are surpassing 200 cases a day or even 300 cases a day, and as the critical cases keep increasing, we'll be able to handle that capacity. But for the CPAP machines themselves, availability is not that good in this side. Yeah.
Thank you. Well, Dr. Thakar, there seems to be a market opportunity there. Do you think?
You know, I have an issue about CPAP and respiratory aids and ventilation, and it's a whole economic issue, and I'm not sure we should be spending too much on it. I think when we have limited resources, I want to save 95% of the Africans more than the 5% who need ventilation. When you have limited resources and you spend too much on ventilations and CPAP, you might be actually putting dollars down the tube. So I think literally saving 80% of the population on field hospitals and making sure they recover and using those simple masks might be good. I think ventilation could be a great discussion of how not to spend money. We don't have ventilators, and I know for a fact it would be great if we had all the money in the world. We would try and save everybody. But actually, you have all seen the recovery rate for those who actually need ventilation in countries like UK and US, right? So I think one needs to be prudent about the spend that needs to get through. I really like the oxygen innovations that are happening, and people start measuring ventilators and how many CPAPs we have and all that. I think those are all wasted exercises.
Thank you very much for that. One area where there does seem to be agreement that we need to spend more money in Africa on is testing. Now, testing is a thorny issue. The UK has been woefully inadequate vis-a-vis testing. The availability, as I understand it, of antigen tests is very, very limited. There's antibody tests, but antigen tests don't seem to be readily available. Am I right in that, Mark?
I think currently it's the other way around, Paul, actually. So we have, it's the antigen tests that the health secretary was boasting about having 120,000 of on the 30th of April.
The antibody tests we don't have.
Well, no, there are tests. There are concern because antibody tests are used to demonstrate whether people may be immune. It's important that they should be highly accurate, because even if you have a false positive rate of 2% and you test 1,000 people, then you're going to falsely reassure 20 people that they're immune when they're actually not. And so getting a test that's reproducible, cheap, easily done, and highly accurate is very challenging, and it's not available at the moment. The antigen test, I agreed with the first half of your comment. It has been woefully inadequate, but that is the test that we're doing at the moment, and it's the antibody test that we're not doing.
Right. Sir Christopher Edwards, I think this is an area, testing is an area that interests you, and you see some possibilities on the horizon.
Yes, I do. I mean, I think that, as was indicated, that the technology that we currently have, it is expensive. It involves what's called the polymerase chain reaction, PCR. And you heard about the question of a number of vans containing this equipment, etc. I'm afraid that this is equipment which takes time, it takes technical expertise, in fact, in order to do it, and it doesn't produce an immediate readout. And so I think what we now need, and this is work that my own laboratory is working on very much, we've got now some novel technology which we hope is going to be transformative in terms of something that's going to produce an immediate readout. And so what the readout is actually going to do is to say, do we have what's called the RNA, which is a sort of code of the virus? Do we have two of the key proteins of the virus? And the test will immediately say, yes, yes, and yes, I tick. You, in fact, are infected, okay? And so the idea is to have something which can, in fact, be scaled up, which could then be available very cheaply for people to have recurrent testing. Because the problem at the moment is that you have one test, and that's it. You go away. In fact, I mean, people have driven two hours to have a test, and that's ridiculous. I mean, you've got to change that. We've got to get to something which is cheaper, easier. People can do it without any kind of technical knowledge, and which can be done recurrently. If you can do that, then we can go back to work safely. The whole world will be transformed. That's what we need.
Thank you very much indeed. And I think on that note, we can now, I think, draw things to a conclusion, because we've overrun our time somewhat. Are there any last remarks or questions that anyone participating wants to raise? Nicole, do you have any in front of you coming up?
No written ones in front of me, no.
Okay, and then in that case, what I'm going to do is to ask our speakers in turn, just for a last minute thought, if you like, to wind us up. Beginning with you, Tanya.
Yes, so my final thought would be that 2 months ago I would have said that COVID-19 fortunately does not affect children, but I think we're now seeing that in fact is not the case. We now have 94 cases of this new pediatric multi-system inflammatory syndrome in New York. There have been 3 deaths this week. And so I think this is still evolving. And so I think we need more research, we need more trials on how COVID-19 affects children. And so that it's still a question mark.
Thank you. Dr. Slade?
I think it's, I'm tempted to defend cheap CPAP a bit. And I take what Dr. Thacker says. I think a key question for any healthcare innovation is the cost per life saved, and I don't know what that would be in in Africa, and clearly public health measures and health prevention, health protection are much more important. But I do think that a cheap, $200 CPAP machine is different from an intensive care ventilator, and saves a high proportion of the lives of patients who would otherwise go on to full mechanical ventilation in a high resource healthcare setting.
An important point. If we can go to you, Professor Dr. Charles Yanka.
Yes.
A minute's
Yes.
thought.
I would like to probably clear the ventilation point. We have the CPAP as well as the BPAP. They are non-invasive ventilation, and they are in a different category. Whereas the invasive ventilation is where you put them on a real intensive care unit for that. Before these patients go into the so-called patient-infected, self-inflicted lung injury, you can use the CPAP or the BPAP, early on when they become symptomatic. So that's why we can save a lot of patients from being going so far to ICU for real invasive ventilation.
Just so I can press you, so we get some clarity in this in terms of
I want to
you
do that.
would like to see more CPAP and BPAP available in Africa.
Available at African hospitals.
Either brought in from abroad or manufactured on the continent itself.
Well, exactly.
Thank you very much for that. Amit, anything you like to say by way of a last minute's thought?
Okay. My only last takeaway call would be partnership and leadership is going to determine how everyone comes back to normal. It's going to determine how quickly we rebound back to Africa. It's also going to quickly determine how our families, kids, and the economy gets back to normal in terms of education, economic activity. So one thing everybody should press on in every country is to hold leaders accountable that it's only through partnership. If any leader feels they can do it alone, they're in for a rough ride. Let's help people on how to effectively use partnerships for us to live a normal life quicker. Thank you.
Thank you very much indeed. Dr. Mbuvi, Paul, before you return to your ward, can you give us a final minute or so's thought?
Okay, so my final comment will be this. As we continue to manage the COVID-19 cases, from my personal experience, I'll still keep emphasizing on the issue of mental health for our patients and for the healthcare workers who are at the front line. If this is kept at the forefront of everything, we'll be able to manage this. And as the rest of the audience have said, the sooner we get to take care of the larger population, then the smaller population that actually requires the invasive care will actually be reduced. So we need to take care of this larger population that is actually presenting. And if we do that, I think we will actually be able to win this war. Thank you.
Thank you very much indeed. Thank you all our contributors.
Sorry, we just had one comment in the chat from Eunice, who's the Director of Quality at Aga Khan, on the ventilation point. So to wrap that up, she agrees that it's something that is definitely worth considering, especially the simple CPAP in the African context and specifically in Kenya. So just wanted to share that.
No, I think that's an important contribution, again, from the front line. I think we need to look at this simple CPAP as part of a wider response, and look also at the opportunities for manufacturing on the continent. This is, this is an area which the Africa Union has identified as a priority area, the clinical and pharmaceutical manufacturing. So let's see what we can do there. But I want to thank all our contributors, all our participants. The point has been made about partnership and leadership. Leadership isn't someone else. It's all of you. It's all of us. We are all, the reason why we're participating is because we have leadership roles and leadership responsibilities. We can all pursue, and we are pursuing partnership. And I think we're hugely grateful to BOBAB and to Medicus for their leadership in and their partnership. So a big thank you to them, to Nick and to Nicole. And you know, I just do think, I think it's worth remembering in terms of us learning and sharing with each other, whether it's US, UK, Africa, the wider global community, we can learn from each other. Africa is coming to this at a different time and in a different context from other continents. That gives us an opportunity to learn, but it also gives us an opportunity to contribute our own experience to ongoing learning. And there's an African proverb, which I always think is relevant in this sort of setting, that if you come late to the kitchen, you don't have to break as many pots. If you come, Professor Yanka, it's an Akan saying, you know it. If you come late to the kitchen, you don't have to break as many pots. So we can learn from others what not to do, and we can share with others what we are doing, what is indigenous and what is from Africa. I think that's a great strength of this platform. We look forward to the next gathering, when we'll be looking specifically on the 19th of May on the issue of mental health and exploring the psychosocial impact of COVID-19. So until then, thank you all. As we say in Ghana, Prof, Madasi.
Right.
Bye-bye.
Thank you. Bye-bye.
Bye.
Goodbye.
Thank you all.
Bye-bye.
Bye.
Thank you for looking in. Thank you. Bye-bye.
All right.